Good afternoon, everybody. It's a pleasure to be here with you today to introduce this research project, the relationship between sleep and Parkinson's disease. I'm a neurologist, but I'm also very interested by sleep. So I have connected Parkinson's disease and neurology and sleep we work in the La Pitié-Salpêtrière in the sleep special ward, a dedicated unit. Now, Parkinson's disease, there are motor disorders and motor symptoms, the symptoms that will lead the patients to see a doctor, but we also have non-motor symptoms which can be invalidated in neuropsychiatry, sleep, sensory, cardiovascular, gastrointestinal, but mostly here I would like to focus on the sleep related symptoms because these symptoms are very frequent. 70% of the patients complain of sleep related symptoms during their disease. And it's important that we document and understand those symptoms to be able to manage them. There are different types of sleep disorders that I'm going to explain later. Now, why do people suffer from sleep disorders in Parkinson's disease? Here we have a section of a sagittal section of the brain, and we have some red dots, and the red dots show the networks that are directly involved in vigilance when we're awake, when we don't go to sleep. Or they also make us go to sleep when we're supposed to, i.e. at night. This is a fairly complex picture, and I have added little pictures showing deposits that can be found in some very specific places, and those deposits lead to sleep disorders, which I'm going to explain. The vigilant sleep systems is relatively complex, so we will not go into too many details, but it can be involved very early on in Parkinson's disease, leading to a number of symptoms, such as a bad sleep structure. The sleep structure will be disrupted and people will suffer from sleep disorders and complain about sleep disorders. And the sleep structures or schemes can also be analyzed, documented in order to understand whether this may lead to other indications, for instance, for prognostic purposes. We also need to know that sleep has a number of functions. Sleep plays a role in memory or how to remember things. If you sleep well, you remember well, or you memorize ideas. And also, it may have a connection with toxin elimination, toxins being cleared during the night, and there is therefore a potential neuroprotector effect of sleep. Sleep can show symptoms, but sleep can also be a marker which we can analyze, and the sleep structure itself, or rather, the fact that the sleep structure is disrupted will lead to sleep functions being altered. And that is very interesting. That's an interesting set of data for us neurologists because we need to characterize those issues. So how do we study sleep? Maybe some of you have already done sleep recording. There are several things here when you deal with sleep disorders and patients suffering from sleep disorders. First of all, the interview, and the patients will report a number of symptoms such as insomnia, or in blue we have somnolence during the day, the so-called restless leg symptoms, which will stop you from going to sleep, and sleep agitation or paradoxical sleep disorders. This can be observed in some patients, sometimes years before the motor symptoms appear. This is what we call the prodromal stage. And finally, sleep apnea. All of these signs and symptoms can be listed and reported by the patient. And then we will perform what we call a sleep recording. I'm showing you a picture here of someone sleeping, a lady sleeping with sensors positioned on her head, on her eyes, on her chin, on her respiratory organs. And all these sensors will record signals, and we have an electroencephalogram, or we also have ventilation being recorded. There are information on her breathing being recorded. And during the night, the recordings will be extremely interesting because they will tell us exactly what is happening during the night. and they will tell us whether the brain is working correctly. During when we sleep, there are several stages. Here I'm showing you the different stages. It's very complex. The waves we record are extremely complex. At the top, we have vigilance. So the patient is awake. Sorry, it's not awake. It's a vigilant phase. The eyes are closed, but there is an alpha kind of wave. And then the brain activity will change during the night. There are N1, N2, N3 stages, and depending on the stage, the curve will be different. The electroencephalogram curves will be different because the brain activity changes during the night. During the N3 stage, we have some very slow waves, looking like sea waves. And this is the stage during which we recover. And we believe that it is also probably when toxins are eliminated and cleared from our nervous system. That can be recorded, but it's most likely that we have neurons here that provide those signals that can be analyzed. The last wave is what we call paradoxical sleep. Now, that is a very special stage, and this is where we have behavior disorder issues because some patients will lose the tone and the tonic control during the sleep, and they are no longer sort of paralyzed, and they will start dreaming and moving around in bed and be very agitated. And sometimes they can hurt themselves. They can either hurt the spouse or fall from the bed. The main sleep disorders. No, the most prevalent one is insomnia, the difficulty to sleep. The fact that it's difficult to sleep through the night. You go to sleep, but then you wake up after a couple of hours and you have trouble going back to sleep. So you miss the last cycle. Prevalence between 20 and 80%. So it fluctuates a lot depending on the trials and the studies and how insomnia was defined. Then we have excessive day somnolence, people who go to sleep during the day. And again, prevalence is 16 to 74%. And it's quite disturbing because it can be very disturbing for your day life. You go to sleep when you're watching TV, you go to sleep when you're reading. But in the worst cases, you may go to sleep while driving. People can resist the somnolence, but sometimes there's nothing you can do. You just go to sleep. And if you're driving, that can be extremely dangerous. And finally, we have the paradoxical sleep behavioral disorders, people who live their dreams very actively, and that the prevalence is between 25 and 48%. Now, I'm showing you the main disorders, and these sleep disorders are not constant. They can increase depending on the alpha-synuclein deposits that will increase in the brain tissues, and they will increase that, they will disrupt the sleep vigilance system, and they need to be monitored throughout the patient's life, and it's possibly very debilitating for the patients. Here, the study was conducted in patients in the early phases of the disease, first 3 years. 40% of the patients already were complaining of insomnia, 25% complained of behavioral disorders during paradoxical sleep, RBD in English, and somnolence 25%. Restless legs syndrome, no difference from the controls, and sleep apnea. Well, the patients with PD did not have more sleep apnea than the control subject. So it doesn't seem to be associated with Parkinson's disease, simply because the patients are often aged and elderly, and that's the reason why we observe sleep apnea. There can be, the symptoms can be mixed together, insomnia with somnolence. And for doctors, it's very important that we characterize all the disorders because sometimes they're connected, but sometimes they aren't. Regarding polysomnographic recordings, so far we didn't have much in terms of correlation. Mostly it's a clinical diagnosis. We don't know whether insomnia in Parkinson's disease is similar to the kind of insomnia we may observe in general population, and whether there are any specific markers recorded in polysomnography. For somnolence, it's slightly different. In the studies we conducted, we found no connection between what was happening during the night and what was happening during the day, i.e., nighttime sleep quality was not connected with the somnolence during the day, which may be quite surprising because if you don't sleep well at night, obviously, you tend to fall asleep during the day. And finally, for RBDs, we know that we have a loss of atonia during sleep, paradoxical sleep. So that's a very good way to diagnose the disorder. Our study that we have thought through before we started it is called SOMPARK. It's funded by the France Parkinson Association, and it provides answers to all those questions that I have just asked in PD patients, but also patients who suffer from isolated RBD and patients who could be in the prodromal stage before the motor symptoms appear. And the objective of the study is to conduct a very exhaustive study of all the sleep-related symptoms in a large panel of patients, recording their sleep behavior in a very accurate way. It's never been done before, at least not at that scale. And we thought that we really had to have a very broad view on sleep disorders. We tried to provide answers to a number of questions. Patients report insomnia very often, so we try to understand when exactly during the disease course it appears. Are there motor issues? Is sleep perception altered? And we know that insomnia in the beginning of the disease may have different causes, but not in the middle of the course of the disease. And also sleep perception is important. I'm always struck because sleep recordings show that sleep is fragmented, but very few patients report that if we compare with patients who suffer from primary insomnia outside of Parkinson's disease. So it's interesting that there is a difference here in the sleep perception. And finally, we have the consequences for the spouse. It hasn't been studied so far, but sleep disorders in patients can have a huge impact on their spouses and also the spouse's sleep. We also wanted to look into somnolence, characterizing somnolence. Night and vigilance have to be considered as one big day, 24 hours. And the day is directly correlated with the night. So we conducted several tests I'm going to introduce so that you have a good picture of everything we've done and what the 24-hour cycle can look like. Finally, we also looked at the connection with concentration deficit. We thought maybe this could lead to cognitive issues and concentration deficit. We also looked at the restless leg syndrome, trying to characterize it because it doesn't show necessarily more at the beginning of the disease, but then with time, the symptom will increase. It may also be due to the medication, but we need to understand the physiopathology because it's different from the physiopathology we observe in patients with restless legs who do not suffer from Parkinson's disease. And finally, for patients who have the RBD, behavioral syndrome, in the prodromal phase, we want to understand whether their sleep is already altered at before the motor symptoms appear, because sleep also shows the brain functioning, and we try to understand whether some of the structures have already started being altered in the brain, and it shows through the RBD. And we try to understand the role played by microbiome and gut inflammation and the connection with sleep. This study is a multicentric study. Again, it's very interesting. Very interesting that we were able to work together on the national level, several centers collaborating. We exchanged on our practices so that we could homogenize our practices, and it provided us with a broader view. A large population of patients, 240 patients, 160 suffering from an isolated RBD, 50 controls. So people who do not suffer from Parkinson's disease. In total, 457 patients included in the trial. And the coordinating center was Paris, but we also had Nantes, Lille, Clermont-Ferrand, and Nîmes with specialized sleep disorder units. So initially there were a few challenges, but we were very happy that we started this year. Sometimes the regulation was difficult to manage. We started enrolling patients, 13 patients. We started in March 2025. Right now, we have prodromal stage patients, but we are starting to enroll patients with already Parkinson's disease. And the other centers have started, are almost ready to start including enrolling patients because they have finally completed the regulatory issues. So how does it work? We have a large white mapping, and this is the protocol. The protocol is fairly short. Between the inclusion appointment and hospitalization, the inclusion interview is 1 day, and hospitalization is 3 days. No follow-up afterwards unless the patient needs to see us and has an issue that we need to see him for. And before the patients are hospitalized, they will undergo actigraphy. Actigraphy is a watch, like a connected watch, like an Apple Watch, that records the day cycle and the sleep vigilance cycle, what time the patients go to sleep, what time they wake up, how many times they wake up during the night, sorry. And it also gives us a very good recording of motor activity and sleep. And with a sleep agenda, the sleep agenda needs to be filled by the patient. I go to sleep at this hour and I wake up at this hour. This also is very helpful for us because for 7 days we know whether the patient has slept enough or not, whether the life has been normal or not. And we can have a very good picture of how the patients come to us in what state regarding sleep. Then they are recovered in hospital for 3 days. And as I showed you on the picture, their sleep will be recorded with electrodes, electroencephalograms of brain activity, but also breathing will be recorded, the heart rate will be recorded. And as far as the electroencephalogram is concerned, we have added electrodes. We have 21 electrodes in total so that we can have a much more accurate picture when it comes to analyzing the recordings, and we can also see much better what will be done in the coming years. So initially, we perform a standard polysomnography. The patient is asleep. And during the second day, we do what we call tiles. Tiles are iterative, in French, iterative tests, which are 5 tests conducted during the day when the patient takes a nap. And during the nap, we can see whether the patients will really go to sleep or not. And this helps us assess somnolence during the day. And between the naps, there are cognitive tests being conducted, which I will describe later. And the third day, polysomnography will be repeated for a second night. And the third day, we do the reverse, the day vigilance tests. So it's the opposite of the tiles. We ask the patient to try and resist going to sleep. In the tile test, we ask them to go to sleep. Now we ask them not to go to sleep. And so it allows us to see the quality of sleep at night, and it also shows us whether the patients suffer from somnolence during the day, and we can characterize objectively the capacity to go to sleep and resist sleeping. On day number 3, we see the capacity to resist somnolence. These exams are conducted in the hospital, in the same ward where we treat other diseases. 21 electrodes are used so that we have a much accurate set of data, and we can analyze the electroencephalogram, and we can do a very accurate, fine-tuned analysis of the signals recorded, and it will tell us whether the brain structures which normally produce a number of signals have been altered. And then at the bottom of the slide, we see the questionnaires. There are questionnaires on all possible sleep disorders reported by the patients. There are questionnaires on the quality of sleep. There are questionnaires on insomnia, bad dreams, nightmares, agitation at night, depression, anxiety, because we know that mood is affected and it has a huge impact on the quality of sleep. We also take blood samples. We collect urines to measure the quantity of melatonin in urines. We can assess the quantity of melatonin in urine. The melatonin is a hormone, and the secretion can be altered in Parkinson's disease. So we measure the quantity of melatonin in urine. We take blood samples, and we also analyze the gut microbiota in order to try and establish correlations with the sleep disorder. I'd like to tell you now about the cognitive tests that we perform between the naps. This test is the Sustained Attention and Reactivity Test, SART in English. This test attempts to assess concentration. The patient wears a kind of helmet with electrodes, and there are figures appearing on the display. And when the number 7 appears on the display, the patient must push a button. And the instruction is when number 3 appears, the patient should not push the button. And so the figures keep coming up on the display for about 30 minutes. And every 5 minutes, the test will be interrupted, will be discontinued, and we ask the patient, are you focusing? Are you focused? If yes, what were you thinking about? If not, what is happening in your brain? Is there a blank moment? Are you simply drifting off and dreaming? Or is your attention focusing on something specific? And how do you feel with regard to fatigue? Are you tired? And then we try to analyze whether any mistakes have been made between the numbers 3 and 7, because after 30 minutes, patients will push the button at the wrong moment and not push the button when the number 7 comes up on the display. So we try to analyze whether that could be connected with local sleep-related abnormalities. For instance, a sleep appears during the day for a few minutes at a time when it's not supposed to be there. It's already been described in patients who have attention deficit disorders. They may go to sleep for a few minutes, so we try and understand that and see whether it might be combined with somnolence, because the patients have been taking naps between the tests. So we try to establish the link between these short somnolences and the attention deficit reported by the patients. So that's the picture for the protocol that has recently started. We hope that understanding better will help us treat better. Sleep is a very mysterious world, but we can actually try and understand this sleep with questionnaires providing lots of information. And we can also perform exams that will help us understand better what is really happening in sleep disorders. I'd like to introduce the other participants in the study. As I said, it's a multi-center study. We have the coordinating center in Paris. There is a PhD student, a project manager, some hospital doctors, researchers. I don't have a picture for everybody, unfortunately. One of them showed a picture of Lille, but not of herself. Here we have all the coordinating centers. Laure Peter-Direx in Lyon, Marie-Aline Lamontigny in Clermont-Ferrand, Patricia Avril in Nîmes, Lorraine Leclerc-Visonneau in Nantes, and Lise Lanvin in Lille. So those are the people who act as coordinators and work with us. In their own centers, they are the coordinating investigator. And we are going to conduct a study with them, and we hope that we will find some really interesting things. Thank you very much for your attention. Thank you. Thank you. Yes, we will keep the questions for the end, but we will be asking you some questions. If you have your phones available with the QR codes, we ask you 2 questions. One question and the other one is just one word. The first question, can we please have the first question? When do sleep disorders mostly appear during PD? Late, B is during the first stages, A is late, and C is never. So please answer based on the presentation you just heard. We will give you a few seconds so that we have many answers. And right from the beginning, at the very early stages, the sleep disorders are already appearing, and we will see whether in some patients, maybe they only appear very late during the course of the disease. Now we're going to move on to another question. We're going to ask you to just say one word, one word. So can we please have the second question? I don't know it by heart. Just one word. One word. What does a good night's sleep represent for you? If you sleep well, if you spend one night and you sleep really well, what would be the word that it makes you think of? So happiness, recovery, waking up in good shape, relaxation, resting, peace, quiet. Recovery seems to be the biggest word. Recovery, rest, peaceful, in good shape when I wake up. I don't know if you want to comment a few of those words. Like, not surprising, really. That's what we expected. And 8 hours non-stop sleep, recovery. Recovery really wins the battle because the big word is the one that most people mentioned. So, okay, we'll keep those words in mind, and we're going to move on to the next speaker, the next presentation. The local speaker, Professor Pascal Kendarick, is going to talk about the gut.